patient who was living alone in Pune. He was an elderly person, and relatives that were not in Pune, they were living abroad. And this fellow had a subtle fall in the house. He had some nasal bleeding and didn't say anything to anybody. Next day, the friends took him to a routine hospital, and this fellow became very, very slow. And when he came, he was wheelchair bound.
Mhm.
And when we took his history, he had bilateral Parkinson's sign, he had bilateral rigidity,
Hmm.
and he had a mask faces. As a protocol, routine protocol, when we have a rapidly progressive Parkinsonian syndrome and a fall behind, I had asked for a CT brain, and CT brain and showed a bilateral subdural.
Can people with Parkinson's continue working and living independently for years?
Definitely, yes. The disease may start very subtly with some slowing of doing fine activities, difficulty in writing, or maybe he's got to mask faces, anosmia, or he may have a frozen little bit of frozen shoulder.
Parkinson's, not just a disease of movement, it's a journey that quietly reshapes a person's body, mind, and everyday life. It begins subtly, often with signs that are easy to miss, but over time it brings challenges that patients and families must learn to face together. No two journeys are the same, and with each patient comes a unique story of resilience, uncertainty, and strength. Beyond the science and treatment, Parkinson's is deeply human, impacting emotions, independence, and identity. In this conversation, we aim to understand not just the disease, but the lived experience behind it, the hope that continues to evolve with advancing cares. Joining us today is Dr. Mangesh Udar, a highly experienced neurologist with over 22 plus years of experience in dedicated practice in Pune. He currently serves as a consultant neurologist at Sahyadri Manipal Hospital, Deccan, and is the founder of the Brain and Spine Clinic. Known for his expertise in managing complex neurological conditions such as stroke, epilepsy, vertigo, and movement disorders, he is widely trusted for his precision and patient centric approach. Beyond clinical care, he has played a key role in academics as a DNB co guide and over the decade as a guide in recent years. He also serves as the Vice President of the Neurological Society of Pune, reflecting his leadership and contributions to the fields of neurology. His blend of clinical excellence, teaching, and compassionate care makes him a respected name in the fields of neurology today. Let's welcome Dr. Mangesh Udar. Hello and welcome to Sayadri Health Talks. I'm Dr. Tushita, and today we have with us Dr. Mangesh Udar.
Yeah,
Hello, sir. Namaste. How are
namaste.
you?
I'm fine, thank you.
Welcome on Sayadri Health Talks,
Yes,
and we are going to have a discussion on Parkinson's today.
yes,
So, like every other ailment of neurology, like Alzheimer's or other conditions, Parkinson's is given a dedicated day in the month of April.
yes.
So that's why the discussion about this in this month. So help us understand what does it mean to have a day dedicated, because we frequently see it, right? So actually is the significance of this day?
Okay, so now 11th April is
Uh-huh.
celebrated as a Parkinson's Day, and this is in honor of the person who has first described this disease. His name is James Parkinson. 1817, he described in a landmark paper about this disease in quite detail, which still holds true. And he had described this disease as a shaking palsy or a paralysis agitans.
Hmm.
And this day is celebrated in honor
Hmm.
of this person, great person. He was a British surgeon,
Hmm.
and he first described this disease. So
Hmm.
11th April is
Hmm.
celebrated as a Parkinson's Day.
Hmm.
Red tulip is a symbol which signifies this
I can
Parkinson's
see
Day.
that, I
Yeah,
think.
you can see the red tulip. Yeah,
Yes,
yeah,
yes.
sure.
So that's about Parkinson's. So Parkinson's is often, it's a big uh, umbrella, I would say, which has multiple conditions under
Yes,
it. So help us understand this a
yeah.
bit.
So Parkinson's disease itself comes under a big umbrella. The initial disease, which is called as Parkinson's disease, is an idiopathic disease which is very common. But under the umbrella comes a whole lot of gamut of other diseases like drug-induced Parkinson's, vascular Parkinson's, or Parkinson's plus syndrome, or normal pressure hydrocephalus, which mimics Parkinson's. So these are the conditions which probably looks like Parkinson's.
Mm-hmm.
You have to rule out by certain clinical diagnostic tests and clinical examination and few laboratory and scan tests. And then once these are done, we can say that yes, this is Parkinson's plus syndrome and this is a idiopathic Parkinson's disease. This is more important because the prognosis and the rate of disease progression is variable in all of these conditions.
Mm-hmm. Mm-hmm.
So Parkinson's has got a long history. It is a very slowly progressive disease with a good prognosis. So
Mm-hmm.
that's why there are many diseases which comes as a mimic. So we need to rule out this disease.
Mm-hmm. So while I have a lots to ask you about Parkinson's, I would want to start with the symptoms of it.
Yeah.
ठीक है? So when it comes to the symptoms ना सर, ज़्यादातर लोगों को लगता है Parkinson's is predominantly tremors
Hmm.
या फिर balance issues
Okay.
या फिर not able to think correctly.
Okay.
So are these the early signs, or what do we if I have to tell people that these are the things which you look out for? So what would be those symptoms?
Okay. So Parkinson's is typically characterized by shaking, that is a tremor in the hand, slowness of activity, which is slowing of gait, slowing of activities, and stiffness. These are the three cardinal symptoms. But this does not usually doesn't come at the beginning of the disease.
अच्छा.
The disease may start very subtly with some slowing of doing fine activities, difficulty in writing, or maybe he's got to mask faces, anosmia, or he may have a frozen little bit of frozen shoulder, mood changes, early fatigue. You can have constipation as a major symptom,
अच्छा.
autonomic symptoms like dizziness while standing up, while the blood pressure falls. These might be initial symptoms which may precede the classical Parkinson's signs by years together, maybe something like 5 to 10 years.
Mm-hmm.
And then these classical features start. So it is important to recognize these features early and then
Mm-hmm.
treat it accordingly.
So, does it hold very strong hereditary recurrence?
No, hereditary does not play a very strong part in Parkinson's disease. There are few percentage which are hereditary. Most of the Parkinson's are non-hereditary. They are
Mhm.
idiopathic, and these are slowly progressive neurodegenerative disease. Uh, Not so much of predominantly hereditary. A very small percentage is hereditary.
Okay. So, what exactly happens inside the brain if you have to, explain it to a layman? So,
Okay.
what exactly happens inside the
So
brain?
there is this area in the brain called substantia nigra,
Mhm.
and this substantia nigra produces dopamine.
अच्छा.
Now, dopamine is a neurotransmitter which is responsible for smooth functioning of the muscle movements. So this is one of the very important major neurotransmitter. So as the neuron starts to die, the amount of dopamine starts reducing, and the response to dopamine becomes erratic. So those movement becomes shaky, movement becomes erratic. They are not stiff. They are not very smooth. They are shaky. There is stiffness of the body, and this is all related to dopamine.
Mm-hmm.
Eventually, as the neurons dies, the disease pathology, there is an abnormal protein called alpha-synuclein which starts depositing in the brain. So
अच्छा.
initially it deposits in the substantia nigra, but eventually it gets deposited in all of the brain,
Hmm.
and then that's responsible for many other symptoms like sleep disorders,
अच्छा.
autonomic symptoms,
अच्छा.
mood changes, and other things.
Actually, I was coming to that. That how important are the non-motor symptoms like sleep disorders or mood changes
Okay.
in Parkinson?
Yeah, so they are one of the backbones of the Parkinson's. Maybe the tremor may not come very early.
Yes.
These non-motor symptoms comes early. As I've told you, it
Mhm.
may be just an anosmia, or rather than anosmia, it would be just a loss of taste. You
Mhm.
cannot say that is that we have an anosmia. The
Mhm.
most important thing which people will feel is loss of taste because of
Mhm.
anosmia.
Mhm.
So this precedes by years together.
अच्छा.
So is a frozen shoulder, so is like a mask faces, subtle slowing. Then there are autonomic symptoms like urinary problems, there is constipation, there are lightheadedness because of autonomic dysfunction, because of blood pressure falling on standing. So this comes, these are non-motor symptoms which precedes the motor symptoms by a few years,
And
say
also,
maybe
I
5
think
years.
these are the most commonly missed out symptoms,
Yes,
also, right?
because these are very common symptoms
Which mimics other
which mimic
conditions.
the condition. So these are, many people will relate these things
Huh.
not as Parkinson's, non-motor symptoms of Parkinson's, but other diseases.
Ha ha ha,
Hmm.
correct. So as we know that there is no single definitive tests for
Right,
Parkinson, right?
right, right.
So how do we diagnose it?
Okay, so there are very good strict criteria as given by the Movement Disorder Society, and there are certain investigations which supports the diagnosis. The uh, key symptom which is related to Parkinson's is bradykinesia or
Hmm.
slowness of movement.
Hmm.
So anybody who is becomes slow in his walking, in his daily activities, wearing clothes, washing, bathing, taking more time, this is the cardinal symptom.
Mhm.
In addition, if there is tremor or rigidity, this supports the diagnosis. So any one of these two with bradykinesia is a clinical diagnosis, suspicion of Parkinson's disease.
Mhm.
Now, with this thing, nowadays we have some tests like a dopamine PET scan, which can help us to support our diagnosis, but the diagnosis is mostly clinical. So if you have this kind of a thing and no red flags,
Mhm.
so we will come to that red flags
Mhm.
later on in the
Mhm.
talk, but no red flags, then this is a classical Parkinson's disease. Usually starts on one side,
Mhm.
shaking of limb at rest,
Mhm.
and then slowness, bradykinesia, tremor,
Mhm.
and rigidity. So these are
Acha.
cardinal signs of Parkinson's disease.
Mm-hmm. So that Parkinson is, I mean, of course, like any other condition, Parkinson is also not same in every patient,
Yes,
but the variations are huge.
yes.
Why do we see such huge variations in patient A who is having Parkinson's versus patient B who has
Okay, so
Parkinson?
there are subtypes in Parkinson's. So some of the patients will have only tremor.
Acha.
So these are tremor predominant. They
Mm-hmm.
will have a tremor of one side of the body which is at rest. So you have just a rest tremor going on.
Huh.
And these people have a very slow course. They are chronic course and they do not progress so fast. They do not develop a lot of autonomic or memory disturbances. And this is
Mm-hmm.
a different subtype.
Acha.
There's one subset which is gait imbalance and postural instability,
Mm-hmm.
GIPG.
Mm-hmm.
So this subset has got a rapid progression. They have a lot of autonomic symptoms. They have frequent falls, and they probably may be subtyped as a Parkinson plus thing.
Mm-hmm.
So this subset progresses fast. This has cognitive deficits. This has behavioral problem, memory changes early in the disease.
Mm-hmm.
So they progress faster.
Acha.
The prognosis is better for people who have a unilateral tremor predominant Parkinson's.
Unilateral
Tremor
tremor
predominant
predominant
Parkinson's.
Parkinson's.
Yeah,
So when it comes to the treatment aspect of it, right,
yes,
we will talk about levodopa.
yeah,
So when do you decide when to start it, and are there any criterias or in the patients which shows that?
yeah. So nowadays, movement disorders have society has graded Parkinson's from grade 1 to grade 5.
Acha.
So in very early stages, young patients, non-disabling symptoms, you may just try out uh, dopamine agonist
Mm-hmm.
or MAO inhibitors to start with if they are not disabling.
Hmm.
But once the movements of Parkinson's starts interfering into day-to-day activities,
Mm-hmm.
like they interfere with people have difficulty
In
initiating the gait, lot of tremors,
Acha.
then you should not withhold dopamine. It's the mainstay of treatment. So
Mm-hmm.
whenever you have motor disability interfering with your day-to-day
Hmm.
activities, daily
Mm-hmm.
activities, dopamine is the drug to be taken.
What is this deep brain stimulation?
Okay, now deep brain stimulation is one of the surgical modalities which is used for treatment of Parkinson's. So this is not used in initial Parkinson's. This is used in moderate to severe Parkinson's.
Acha.
This is used in people who have tremor predominant Parkinson responsive to levodopa.
Mm-hmm.
This is used in people who do not tolerate levodopa. So even if you give small doses of levodopa, they start having a lot of dyskinesia.
Acha.
If it's a unilateral, it's still better, but bilateral is not a contraindication. So you can have it in bilateral also. So
Acha.
deep brain surgery right now it is limited because of the cost, but it should be restricted to people who have moderate to severe levodopa disease tremor predominant, and with lot of motor fluctuation because of drugs.
So, one thing about Parkinson is when it comes to treatment part of it
Yeah.
is the role of counseling,
Yes.
right? So, a lot of counseling is required for the patient family, because sad enough that Parkinson eventually worsens. I mean,
Yes.
over a period of time, it
Yeah.
might worsen a little slow in some cases, faster in some cases.
Right.
So, how do you deal when it comes to counseling these patients? Make or most importantly, the family part,
Okay.
how do you deal with such
Okay,
cases?
so it's a very common problem, and it's a very important problem. So you do not start discussing this right on day one. So once you've identified a patient, if it's a milder patient, start with treatment. Tell
Mm.
the people that look for the signs to come. There might be symptoms which will be coming eventually. It's there's no time frame or time gap which you say कि इतना दिन के बाद ये आएगा.
बट सर क्वेश्चन तो पूछते हैं ना पेशेंट से,
Yes.
डॉक्टर साहब ठीक तो हो जाएगा ना?
Yes. So first reassure them that this is a chronic disease, this is a treatable disease, and there are medications available.
हाँ.
As and when required, the medication doses needs to be adjusted, and the family will be sufficed. If the patient is ambulant, he's not very he's not bed bound or wheelchair bound, or he's not very disabled by the motor symptoms, then eventually the treatment will be titrated, the doses will be titrated, drugs may be added more for his tremors, for his other symptoms, so that the disease is under control and his day-to-day activities functioning, and even his professional life uh, occurs on a smoother basis. But once a symptom starts to increase, when we pass on with a stage where symptoms appear to be more aggressive, then that's the time when you start talking to the family for the longer time. But initially you talk to them that they may have few more tremors, you may have freezing, you may have dyskinesias. If you have this, do that. So modifications will be told to the family. But eventually second, third consultation, the family has to know that this is a chronic disease. There is no permanent cure to it, but there are plenty of medications and research going on where the patient can be helped and his symptoms can be alleviated.
So, sir, Parkinson shows tremors.
Yeah.
We also know quite a few medical conditions which also has tremors.
Yeah.
So, how do we differentiate between these two?
Okay, so I think it's a good question. Not every tremor patient has a Parkinson's. So you have to differentiate other etiologies which can mimic Parkinson's. The first and foremost is an essential tremor, which is quite common. Essential tremor usually is an action or a postural tremor. It happens in a crowded places. Patient has shaking, and he usually does not have rigidity or bradykinesia. There might be a family history of the same. So that is one differential which is important. The second differential would be a drug-induced Parkinson's. So
अच्छा.
the patient is typically Parkinsonian, but if you go into his drug history, there are drugs which are given as an antipsychotics, or some drugs are given as prokinetic for uh, patients with stomach symptoms, or antiemetics. These drugs can produce a Parkinson's like thing. I've seen most important part is this is a reversible thing. So that has to be drug induced Parkinson's has to be ruled out. Then there are Parkinson's can be seen in patients with normal pressure hydrocephalus. These are the
अच्छा.
people who have excess fluid collections in the brain, and they behave like a slow gait with urinary symptoms and memory symptoms. So that is one disease which has to be excluded and ruled out. Then there are multiple medical conditions like thyrotoxicosis, excess of tea, coffee, excess of caffeine, smoking. Those can cause tremors, and a careful history would try and pinpoint to this thing, and this should be a reversible Parkinson's. The last thing comes as vascular Parkinson's, so Parkinson's plus syndrome. So vascular Parkinson's is a Parkinsonian syndrome which comes in people who have multiple strokes or recurrent strokes,
अच्छा.
and then they start becoming slow. These are the infarcts which occurs in the strategic areas where dopamine is produced, and because of this damage, the people look like Parkinsonian. So this is a vascular Parkinson's like thing. And the last is Parkinson's plus. Now this kind of Parkinsonism or Parkinson's plus is a rapidly progressive disease. It consists of multiple system atrophy, progressive supranuclear palsy, that is PSP, and CBGD, like corticovascular degeneration.
Hmm.
These people usually have early memory issues, gaze abnormalities, recurrent falls, early cognitive changes, sleep disturbances, hallucinations. So these are to be carefully looked at when you are going to explain the prognosis to the people. So these are the mimics which a
Which are the other
Parkinson's
conditions
can
which
have.
commonly mimics Parkinson's.
Yes.
So you have given over more than a decades of experience to neurology
Yeah.
and your expertise to Parkinson's, and you have seen the treatment of Parkinson, for that matter many other conditions also. The treatment has evolved over these years.
Mm.
So what is that one thing, or maybe multiple things, or research wise, technology wise, which is coming up in fields of Parkinson's, which really excites you, looking at the future when we talk about treatment of Parkinson's?
Okay, so initially the treatment of Parkinson's was dopamine. So it used to be dopamine given orally, and because of its short half life, it has to be given multiple times, and eventually patient would have some kind of a reaction where they would develop dyskinesias.
Hmm.
Now there are newer and newer drug delivery systems which are being developed where the levodopa is given in a different way, like gel form
Hmm.
or a subcutaneous form, injectable form. So these newer drug delivery systems are being invented.
Mm-hmm.
Then there are newer DBS techniques which are coming up. There is focus ultrasound, which is available, which can cure a unilateral tremor predominant Parkinson's. There's a new drug called as a tavapadone, which is being developed, which is a once-a-day pill for Parkinson's disease.
Acha.
So that is a very a good thing which for Parkinsonism. And there are many research things which are going on, like anti-synuclein therapy, gene therapies which are underway. So lots of things are happening in Parkinson's right
Okay, so that's about Parkinson's. Now moving on to the next segment of this podcast, where I have few questions for you, and I
now.
need quick answers for
Okay.
these.
Yeah.
These can be myths also.
Yeah.
Yeah.
Hmm.
So the first one is Parkinson's only a disease of old age?
No, Parkinson's is usually a disease of 60s, but if it is, it can even occur in less than people who are 50 years or younger. It is called as young onset Parkinson's
So
disease.
what's the youngest Parkinson patient you have seen or heard?
I have seen a person 35 years who has Parkinson's disease.
35.
35. Then there was a family history for the same.
Okay. Can lifestyle factors like exercise actually slow down the symptoms?
uh, Rather than slowing down, it will affect in a positive way to his day-to-day activities. So it can help him be more confident and deal with the symptoms better rather than slowing down the symptoms.
Acha. Does every tremor means Parkinson's?
No, not every tremor means Parkinson. There might be many causes. We have discussed it already.
Yes, we did. Is Parkinson's always hereditary? I think I already asked you this.
No, Parkinson's is not always hereditary. It's mostly idiopathic. Rarely, in a small percentage, it is hereditary.
Very small percentage
Small
is
percentage.
hereditary. Do all patients eventually become wheelchair bound?
That's a myth. Many patients uh, go on in their life managing their symptoms in a very nice way.
Mm-hmm.
They never, not always, everybody becomes a wheelchair bound.
Mm-hmm. Can diet make a meaningful differences in managing the symptoms?
It's not the it's not the method to manage the thing, but it can make some positive impacts, like high fiber diet, keeping protein around the syndopa dose. It might reduce the fluctuations and help him in a better way rather than
Directly
directly
impacting or
impacting certain
directly
things.
helping? Okay. Is it true that Parkinson's only affects movement and not the mind?
No, it's a myth. Parkinson's is disease of body, movement as well as mind. So there are lots of things in the mind which happens: fatigue, depression, apathy, hallucinations. So it's the disease of movement and mind together.
Can early treatment change the long term course of the disease?
It does not change, but it helps in getting the symptoms addressed properly and
Managed better.
appropriate management given at the right moment.
Is deep brain stimulation a cure or just symptom control?
It is a symptom relieving thing. Deep brain stimulation will elevate the unilateral bilateral tremor predominant levodopa responsive tremor rather than uh, curing the Parkinson's.
Acha. Can people with Parkinson's continue working and living independently for years?
Definitely yes.
So, what would be that one last myth about Parkinson's which you are tired of hearing and you want to burst it for,
Okay,
good?
so they say कि once you have a Parkinson's, it's a death sentence.
Oh,
So I think I want to strike it out. If you have developed Parkinson's, proper change in lifestyle, proper management of symptoms, proper routine visits to a neurologist, physiotherapist, gait training, psychiatrist or a psychologist, and an occupational therapist will get back these people to work. So it's not a
end of the
incurable
life.
end of the life. People have lived years together with Parkinson's.
So, just manage it right.
Manage it right. Yes.
So that's about Parkinson's and our discussion for today.
Mm.
But before we let you go, we have a ritual at Sahyadri Health Talks where we listen to stories.
Yes.
So it's time for you to share some story about some patient recovery which is very close to your heart, and you still remember that case very fresh in your mind.
Okay, so I remember one patient who was living alone in Pune. He was an elderly person, and relatives that were not in Pune, they were living abroad. And this fellow had a subtle fall in the house, and he had some nasal bleeding and didn't say anything to anybody. Next day, the friends took him to a routine hospital, and the nose bleeding was sorted out.
Taken care of.
Eventually, over a few days, this fellow became very, very slow, and when he came, he was wheelchair bound.
Mhm.
And when we took his history, he had bilateral Parkinson's sign, he had bilateral rigidity,
Hmm.
and he had a masked faces, some urinary symptoms. And as a protocol, routine protocol, when we have a rapidly progressive uh, Parkinsonian syndrome and a fall behind, I had asked for a CT brain, and CT brain had showed a bilateral subdural. So
Oh.
there were blood collections on both sides of the brain, mimicking like a Parkinson's. And this fellow became completely all right after evacuation of this thing. So one fellow which I remember very vividly.
Okay, so that's about that case. And before we end this podcast for today, what would be your one final message to all our viewers? Some of those who are fighting with Parkinson's every day, families who are managing, because living with Parkinson's is also equally
So
very important.
yes.
So, what message do you have for all our audiences out there?
Okay, so as I said, if you are diagnosed with Parkinson's, it's not a death sentence. We know that it is a chronic disease, it is a chronic progressive disease with eventually more and more symptoms coming on. But as medicine is advancing, we have plenty of medications to tackle these symptoms at right time, a right approach to physiotherapy, balance training, uh, bladder training would definitely get these people on their feet, and they would make them eligible for even work to for years together to come. So Parkinson's is a chronic disease, so you take it as it comes.
So, Parkinson's is a chronic disease, live with it and manage it well.
Manage it well.
On that note, thanking you so much for giving us this time on Sayadri Health Talks today. We look forward to have you again with some more interesting topics, or maybe with another, format of this podcast. Until then, thank you, sir.
Thank you so much.
This is Dr. Tushita signing off, Sayadri Health Talks.